First of all, I have to say it's fascinating work both of you have presented, and we frontline clinicians actually owe a great gratitude of debt to basic science researchers like you to kind of further our understanding of diseases which we grapple day in and day out. And slowly but steadily we're getting there. The evidence is being generated by the likes of you, and thank you for that. So we'll start with a question for Erika from the audience. 1 second, let me. There's a question from Dr. Prakash Monikov about the microbiome. So spontaneous intestinal perforation is quite different from NEC. Does the microbiome have any role in SIP, or is it completely unrelated? Have you found any evidence to that?
That isn't a patient population that has been well studied. My guess, generally we see SIP much earlier in time. So I think SIP is much more likely to be a vascular condition. So I don't think the microbiome will have had as large a role to play in that disease, but it has not been well studied.
Okay. One more question for you, Erika, which says, because there are concerns which you raised about the safety of probiotics. So saying, should we be looking at prebiotics rather than probiotics? Is that the way forward? And how much experience do you have with that?
I definitely think prebiotics are important and likely safer than probiotics. I think the key thing with any of these things is that we should understand the mechanism of what we're giving. So, you know, obviously the best source of prebiotics is going to be mother's own milk. I mean, I would actually argue that mother's own milk is going to be better for this than donor milk. And that is a great source of oligosaccharides and other prebiotics. But the advantage to prebiotics is that they are more specifically studied. I think one of the concerns with probiotics is it's kind of used as a general term. It's interesting, you know, we would never just use any old antibiotic or any old vaccine. These are categories, but people sort of think probiotics, you can just use whatever you have and they're all the same. And that's where I think the danger is.
One last question for Erika before moving on to Akhil. So sorry, this is for Akhil. A couple of people have asked this question. So translating your work into the clinical arena, you talked about the possibility of increased oxygen consumption during transfusions, like with feeding. In your practice, both of you, Erika and Akhil, do you stop feeds during transfusion?
Erika, do you want to go first?
The practice of our nursery is to stop the feeds around the time of transfusion. You know, there have been studies done, I don't know if they were in the ones that you presented, Akhil, where there was still significant, you know, quote unquote, transfusion related NEC, even when feeds were held. But, you know, I think that's an abundance of caution, not necessarily, you know, clearly supported. There are situations where we have not been able to, for instance, get another point of access to be able to deliver IV fluids during the transfusion, because by doing this, we require 2 lines. And in those situations, occasionally we will feed, but the general practice is not.
How about you, Akhil?
You know, this is a great question, because, you know, you deal with this situation both as a human being and as a physician. As a human being, all of us find it extremely hard to see a baby crying with hunger. In terms of science, you know, there are some studies definitely which show that withholding feeds during transfusions might make it safer. The quality of science is soft because we haven't been able to decide that if we stop feeds for how long. Because if you look at sonographic studies, then the reversal of feeding or anemia or transfusion-induced alterations in splenic blood flow, those are variable, but probably longer than any of us have stopped feeds. So in many studies, we have stopped feeds for the duration of the transfusion. But as you saw, it's not the transfusion which is the devil. It may be a combination of anemia and transfusion. And the severity of anemia has also varied between studies. The other issue is that the effect of transfusions in the causation of anemia is only in a minority. So I do not think we are ready for it yet. I think this question needs to be looked at all over again in a greater degree of detail, because all of us go through this psychological, philosophical dilemma as to, do I know enough to stop feedings from this crying baby?
So do you or do you not stop feeds? What's the practice on your clinical unit?
We do.
Okay.
But the transfusion, it's a very soft decision.
Okay. Sure. Thank you. I'll hand over to Monica to carry on with the question.
Same
Thanks.
question, like same thing, but a little different question is that Dr. Kishore Sanghvi has asked, because you said about the threshold of transfusion, what should we balance? Because if we go down, we are seeing NEC. If we go up, we see ROP and BPD. So what do you strike balance? You gave the answer about the animals that you put a cutoff of 24, but what about the humans? What is the cutoff in your unit, and how do you balance it out?
So we're still using a cutoff of 24, because most criteria, most guidelines for transfusion have been restrictive. And increasingly, the studies have showed that by reducing the number of transfusions, you reduce the exposure to donors. And in the major outcome measures, there has not been a difference. Where the doubt has begun to come in is from the studies that we have done in collaboration with St. Louis University. In the gut is gut. What we are beginning to find is the difference in the neurological outcome. And I think that may be something that needs to be followed. The difficulty is we're still not sure as to what is the best experimental setup, because mice do not have fetal and adult hemoglobins. So this is something we might have to do using a porcine model. We're still thinking about it. We are not there yet. But what I'm meaning, the short summary for that long answer is that neck or intestinal outcomes might not be the end point to answer this question. We might have to look at other organs at the same time.
Okay, so 24 you mean is your unit cutoff, right?
Yes, because that's how we've been defining severe anemia. And the occurrence of NEC, fortunately, is still in a minority. And it seems that there are two subsets of infants with NEC. One subset may be practice related, because as all of us have started, instituting certain practice improvement measures, we have seen important reductions in the incidence of NEC. But then the second subset might be biological. So even in the best of practices, the incidence has sort of plateaued at 3%. So that's where the confusion is. The number of infants affected is small, and the impact of practice changes seems to be unkind.
Okay, thank you. Dr. Erika, Dr. Amir Ahmed is asking, is there any difference in the microbiome of a baby born vaginally and cesarean section, and would you change your practice, if the baby is born vaginally or in cesarean, while you think about giving probiotics?
There's certainly been data in full-term infants that shows difference between vaginal and cesarean section delivered infants. The studies of preterm infants, however, have shown that the primary driver of the microbiome is really just gestational age. And so that was a bit of a surprise, whether that is because the balance, so we definitely have more preterm infants that are delivered by cesarean section, is affecting the data, or whether the practice in the neonatal intensive care unit over time is such that it very quickly drowns out the effect of vaginal delivery is not clear. But we just recently published a paper that actually showed that the first 48 hours of antibiotics also doesn't affect the long-term microbiome or outcome. So I think that the overall course of a preterm infant changes so rapidly after delivery, that is not a clear difference for our patient population.
Okay. And Dr. Arif wants to ask you that does use of Prolacta, that is humanized HMF, would reduce the risk of NEC because it's coming up in a big way and it looks quite expensive, and should we go for it or not? Yeah.
So it has been shown
What's
to
your view on
decrease
that?
the incidence of NEC. It's actually been associated with the transfusion-related NEC as well. There was some comment, I think, that there was a difference in bovine feeding associated with transfusion-related NEC, but it is very expensive, as you know. So we are not using it.
I would agree with that.
Just because of expense, or it's because of some other reason?
The expense is probably the primary reason that we aren't using it, but I think there's other ways to modify the microbiome. You know, at that point, that I still am a strong proponent of own mother's milk. So even that, that formulation is not going to be the milk of the mother of that baby. There are pasteurization procedures, so you are losing much of the benefit. There's certainly, in terms of informing the microbiome, there are organisms that are passed from mother to baby. So you're losing a lot of that. You're losing in the pasteurization process a lot of the benefits of own mother's milk. So I think really, if you're going to consider resources and costs, ways to improve own mother's milk is still going to be better.
May I add a sentence to that? So this was a question that came up from UAE recently. One of the physicians had asked, what did I think about it? And I think because the advantages or disadvantages are very relative, some of these might have to be considered by what is the existing incidence of NEC in your unit? Because if the incidence is, say, 10%, then the advantages would become more evident. In our units, the incidence is lower. So the disadvantages become more prominent. I don't know, Erika, what do you think?
I think that is an important point. I think the other issue, though, is even if it's 10% of infants developing NEC, that's still a large group that isn't developing NEC. I think one of the issues that neither of us mentioned in our presentations, but it is relevant, what we could really use is some biomarkers or some ways to predict the patient population at highest risk for NEC. And to those patients, perhaps you could consider more of these interventions. But at this point, where the only risk factor that we can identify is prematurity in general, so we have to administer whatever therapy to all the premature infants, that makes it difficult.
Yeah, Hafiz, you want to ask? Because I'll
Yeah.
ask a question.
Yeah, I have one question for myself. Just bringing both your research streams together, is there, because transfusion seems to affect, have some sort of effect in relation to anemia and NEC, so does the microbiome. So Erika, in your studies on the microbiome of children who were affected by NEC, was there a difference, significant difference in the group which was transfusion associated? Have you looked at that? And the non-transfusion associated NEC, which just happens out of the blue?
That's a very interesting question. We actually have not looked at that. I don't know, Akhil, have you looked at that or seen literature?
We haven't either. And I also, philosophically, since we started looking at these studies, both in humans and in mice, interestingly, it is the effect of anemia, clinical or subclinical, which is becoming more important to us. NEC is only the tip of the iceberg, because in the studies with St. Louis, once we started looking at cerebral outcomes, then you start worrying that in the attempts to reduce the exposure to red cells, do we have the full story yet? And maybe we don't. So is it early initiation of Darbepoetin or something like that? Because as Erika mentioned, all of us worry about exposure to red cells from other people, right? Or milk from other people. So I think the answers are yet to come, but I think these have to be very carefully considered.
Yeah.
Monica, any more questions?
Yeah, Dr. Saad is asking, Akhil, can this NEC be just a type of a graft versus host reaction when we are seeing it after transfusion?
That's a very interesting question, a very different way of thinking. The reason we have not thought on those lines is because the inflammatory response is primarily myeloid. The way we have thought of graft versus host reactions is as involving lymphocytes. And here, at least in the studies that we have done, primarily the inflammatory response is myeloid. And that's why we haven't gone in that direction. Now, would we identify a subset of myeloid cells which are activated by antigens? That is possible. There are some studies which are showing that there are certain myeloid cells which might not be innate immune cells. And if that happens, we might have to think differently. But right now, we don't think so.
Okay. Dr. Erika, Dr. Dua is asking, would you recommend probiotic in a preterm infant who is post-NEC now and a baby who is short bowel syndrome?
So that's interesting research that's going on. I do think that probiotics can have a role in growth, but we're then left with the same issue. We still would need to identify a specific probiotic. So, you know, probiotics is not a single therapy. You would still have to identify a specific agent, a specific mechanism to understand it well. So I do think the microbiome can have a role in regeneration. We have to understand more before we recommend a product.
Another question for you, Dr. Heba. I mean, they're thinking really ahead. I think you made us all think like that, like, you know. So they're asking, do you think that dysbiosis happens during intrauterine life? And so if we give, you know, these probiotics to these pregnant moms, the prebiotics to this pregnant mom, they can help to decrease the incidence of NEC?
So I think that's a great idea. I am actually personally not necessarily a believer in the intrauterine microbiome. There's been conflicting literature around that about whether or not there really is an intrauterine microbiome. However, the initial microbiome to the baby does come from the mother. We know that preterm delivery itself is triggered by alterations in the microbiome. You know, sure, we could eradicate NEC if we could get rid of preterm delivery. So maybe we could give probiotics to mothers for whom we are not as concerned about their immune system and some immaturity there. And perhaps there could be a role in decreasing the incidence of prematurity itself. But I do think that administering the probiotics, again, if we knew what agent to give, would be a way to perhaps alter the initial microbiome that babies are colonized with in ways that might have an effect.
Thank you.
We'll probably take one last question and then wind up. So this is in relation to feeding. One of the risk factors of NEC has always been growth restriction and reduction in the umbilical artery flow antenatally. So I know the ADEPT trial from the UK didn't show much of a difference in terms of delayed feeding if you had absent end-diastolic flow. And also the speed of feeding, the SIPS trial showed even rapid feeding versus slow feeding, the increments didn't show much of a difference. So what is your policy, both of you on your unit, of feeding small for gestational age infants or preterm infants with restricted umbilical artery flow on antenatal Doppler?
Erika, do you want to go first, or?
We are cautious, but we still advance by 20 cc's per kilo per day. We don't, I mean, the meta-analyses have shown for sort of general preterm populations, anything up to 40 cc's per kilo per day didn't seem to have an effect. So we aren't feeding to that extent in general preterm infants, but we also aren't decreasing the rate for those who are specifically small for gestational age either.
Okay. Do you delay starting the feeds at all?
No, if the baby is otherwise appearing well, we do not. We might delay the start of feeds if the baby was specifically unstable after birth, but not based on earlier Dopplers.
Okay.
So there are The way I have begun to think about this issue.
Sorry, Hafiz, there are very questions. Yeah.
Sorry, can't hear you, Monica.
No, Akhil want to say something. Yeah.
Yeah, sure.
So the way I have begun to think of feedings has changed. After looking at the mouse model for the transfusion and anemia-induced NEC, I have started thinking of transfusions or feeding or hypothermia or congenital heart disease more as the triggers. It is the previously inflamed intestine which might be affected by a trigger. So I think we may need to look at these problems in two components. One is as to what is the previous status of the intestine. And second is we need to find ways to monitor infants who are at higher risk more carefully. And to me, the most exciting thing that's coming up is the handheld ultrasound. I think 5 years from now, I think I will be doing those ultrasounds. I will be following the splanchnic blood flow. I will be looking for evidence for mucosal thickening and so on. Right now, as Erika said, that's exactly what we're doing. We feed carefully, we keep watching those infants. We fail sometimes, and those babies develop.
Yeah, I think there are a couple more pressing questions which Monica wanted to ask. Monica.
Yeah, I mean, it was interesting question. So I wanted to ask, like, is it only RBC or other blood products have the same kind of a trigger? And you would be cautious on those as well. And another question is there any really role of antibiotic in the neck? Because neck is like going inflammation because of other reasons. So that's by Dr. Arif. Yeah.
Do you oh, yeah. So we have looked at obviously the role of red cells. In our models or in our review of clinical literature, platelets seem to augment the severity of intestinal injury, but do not trigger that. So, and the number of white blood cells in the transfused aliquots of blood does not seem to be large enough to cause injury, because at least in the United States, most blood banks are increasingly using precautions to reduce the number of white cells. There still are some lymphocytes and monocytes, but considering the fact that transfused blood did not cause NEC in non-anemic infants is an important consideration. Transfused blood in infants in periods before, like in earlier weeks, did not cause NEC. So increasingly, the way we have begun to think is that whether there is a substrate and blood is an inducer. So that is the change. So our goal will be to look at the substrate increasing.
What about the second question, antibiotic and neck? I mean, do we really need to give antibiotic in neck? Because is it really infectious?
That is a great question. So there have been a couple of studies which have shown protection. But so will antibiotics protect against NEC? Possibly. Do we want to give antibiotics? Possibly not. Because then what will I give when a baby actually becomes septic? So that is a question, because the number needed to treat with antibiotics to prevent one case of NEC will be fairly large. And you all worry that will it lead to increased antibiotic resistance, and will I have anything to give to a baby who's critically ill?
I think there were early studies done on that, and that's exactly what they showed, that there was a decreased incidence of NEC and an increased risk of antibiotic resistance. So it's not done routinely. I didn't know if the question was about giving antibiotics once a baby was already sick. In that case, I think part of the issue is you have a damaged intestine and risk at that point for bacterial translocation. So even if there isn't a positive blood culture, for sure there is bacteremia that you're not capturing, and the antibiotics have a role at that point. I don't actually think it has a role. Once we have clinical symptoms, the process is very far along. I don't actually think at that point the purpose of the antibiotics is to try to mitigate the actual intestinal process. The inflammation has started. However, you can decrease the risk of further compromise from bacteria that are translocating across that damaged intestine.
Okay, I think we've covered most of the questions asked, and probably it's getting late now for everyone east of us and slightly for the people here. So we'll wind up here. Sridhar, do you want to give the parting remarks?
I think there is some.
Sorry, Monica, you mentioned something?
Yeah.
I'll catch up on the video. Thank you, Akhil.
I want to stop here. I just want to ask one last question, because I think asked, like, irradiated blood, would it help in decreasing the NEC? That would be the last question.
It's a great question. There are some clinical studies which suggest that yes, there is a reduction, but I think we need to study it very carefully in the mouse models, because the number of cells which are being, white cells which are being transfused inadvertently in red cell transfusions is small. So if I were to make a guess, then probably not a major difference. I don't know, Erika, how you think about it.
I agree with you. I don't think it's going to make a significant difference, but we don't know. We don't have information to answer that one or the other.
So, Sridhar, do you want to?
I have many more questions. I think I will post them to you, and you guys can answer, and I will post back to the people who are asking them, because there are, I think, 30 more questions and time is limit, so we'll do that later. So Sridhar, can you do a closing remark to thank the speakers? Yeah.
Thank you. I mean, apologies that I couldn't join earlier, but Akhil is a great friend of mine, and first time I'm meeting him face to face, so to speak. So nice to see you, Akhil, and thank you, Dr. Erika. The discussion was great, and I hope all of you enjoyed very useful session. And thank you, Monica, for all your hard work behind organizing the successful NNF meetings. Akhil, do you want to say anything about your global neonatal network, or have you mentioned already?
Thank you so much, Sridhar. So I wanted to, this is a great opportunity. You know, one of the things that we all think about that when I study NEC or Erika studies NEC, we think the natural incidence is 3%. When somebody from Egypt asks us, hey, what is the incidence? What do you do about NEC? And I ask them, what is your natural frequency? And they say 10%. And I go to somebody in Tokyo or Osaka, they say, what is NEC? We only see sepsis. So we desperately need a global organization to look at what are the regional differences. And it is quite possible that by just looking at regional differences in the incidence of a problem, many answers might come up. The second thing is that the incidence of the mortality in neonates is 20%, which is the same as the mortality in the elderly. But babies don't vote. So the incidence, the importance our societies give to neonatal mortality is far lower. So when we talk about, say, I was talking to a person this morning in the Rotaract Club, and the question was that, you know, our donations are small. They're $30,000. And I told them that you're interpreting it in terms of what we could do for the elderly. But $30,000 is a huge amount to make a change for a newborn. Maybe 5 bag and mask ventilations could add 70 years of life or another functioning brain. So that's why we need a global organization. That's what I wanted to say. Please join this organization. There is no fee. All we need is your voice. And we need to think together as to what we can do for the babies.
Thank you. I wish you all the best for that venture. I think you and Dr. Kamlesh are doing a great job, and Dr. Monica and other colleagues are spreading the word here along with me. So appreciate your involvement in this. I think with this, we will conclude the meeting, and I would like to thank Taufik, Lillian, and the KIC team for their great support as well, and Fadi, of course, for all his behind the scenes work, literally behind the scenes as well. So appreciate your being here, and we will have this recording on the NNF YouTube channel. I think hopefully in the next 2-3 days we should have it up. And those of you who are here, please spread the word so others can gain by watching the channel as well. So thank you so much for being here. Good night.
Good night. Thank you, everyone. Good night.
Thank you, Hafiz.
Thank you,
I
everybody.
forgot to thank you. You are our own team, so even though you
That's
are
all right.
invited.
It goes without saying.
That's true. Thank you.
Thanks again. Yeah.
Thank you.